Hey everybody, welcome back to another episode of Mind Matters, Navigating Head Injuries and Concussions. My name is Kylie Como. I'm your host for this episode. I'm the legal nurse consultant with Shane Smith Law, and today I'm joined by our friend Dr. Erik Reis from the Neural Connection. We're going to have kind of a second part to a discussion we had. If you didn't catch that first episode, I would highly encourage you to go back and check it out. Very informative and entertaining. But let's get going. Dr. Reis, so good to see you. Do you think, you kind of try to stay up on the latest and greatest trends, all of that. So do you think there will be, a breakthrough in somewhat of an objective test for, concussion detections in the near future? Or do you think it's going to kind of stay or really rely on more subjective symptom reading?
I think where we're at right now, a lot of providers and even more patients think that their concussion symptoms are going to show up on an MRI or a CT. And they're going to be disappointed to find out that they're rarely ever going to show up on an MRI or CT. Now, let me just be clear, right? So when you look at a diagnostic test like an MRI or CT, it's phenomenal for finding things like brain tumors, brain bleeds, venous malformations, things that are structurally there that are impairing the ability for the brain to function. And when you catch that, amazing, world-class state-of-the-art, right? But you're looking at structure. What these things can't do is they can't tell you about function. And the analogy that I give patients is to say, listen, Kylie, you would never just go buy a car off the internet, and you never just go buy a car that you just see sitting on the street. What are you going to do in that car? You're going to get in the car, you're going to check to see if inputs match outputs. If you take the car and put it into drive, does it actually turn into drive? Does the brake pedal work? Does the gas pedal work? You're testing the function of the car. The car may look great, but if there's no engine under the hood, or if the battery's not hooked up and there's no electrical circuitry, the car's not going to run. And that's really where I see what we're doing clinically, saying, listen, I care about your MRIs and CTs, but when you don't have findings show up, to me, that's a green light to say, hey, great, you don't have any massive red flags of tumors, brain bleeds, venous malformations, but it gives me more conviction to say, now I need to look at your function. And while I'm optimistic that different diagnostic tests are going to give you more function, I still need to look at reflexes. I still need to look at things like your palate. I need to look at different aspects of cranial nerve exams. Now, until we develop amazing software that can generate all of that data for us via AI and high-def cameras, I still think we're stuck doing some bedside examinations, which, to be fair, is not a bad thing because it allows you to build a relationship with your patient. But there are a couple tools that I am really excited about right now, and I'll give those to you. So when you're looking at balance, a lot of times we'll put people in a position called Romberg's, feet together, eyes are closed, eyes open, eyes closed. You can put different head postures with that too. There are things called dynamic posturography platforms, which can actually use graphs and force plates to graph out sway patterns. So it's an objective way to quantify your balance based off of these different parameters. I like those because I think they can give you data, it's objective, and you can't argue it. I like that because it's great for attorneys, it's great for patients, it's great for doctors, and it's a great way to show progress. So I do think that that's interesting, and we like using those clinically. The other thing that I like doing is something I alluded to earlier, which is video nystagmography. Your eyes are a massive window into the brain. And so if we can quantify different aspects of eye movements, maybe it's the speed of a drift of your eye when you're in the dark and you develop a pattern of nystagmus. Maybe it's the velocity of your eye movements as you go from like my thumb to my thumb and you make a saccade. Different aspects like that we can quantify as best as we can and show, once again, here's where you are today, here's you are in 2 weeks, 4 weeks out. Those things are tough to argue because they're objective and they're showing you the state of the nervous system at that point in time, but it's also a test of function. We're diagnosing people with like Parkinson's and mild cognitive impairment and different types of neurological disorders based off of visual tests now. There's different types of software that can look at the back of your retina to look at and tell you your age, your sex, your blood pressure, HbA1c readouts. I mean, there's a lot of really interesting tech coming out that's going to be looking at that. And so the functional component for me will always win because we have great structural ways to assess you. But until we can see the inputs and if they match the outputs, that to me is going to be the gold standard that we need to set.
That's beautifully said. I 100% agree. And you kind of started getting into some of it, but something we see a lot of in the clients we get here at the firm, especially those that have suffered concussions or mild traumatic brain injury, as it were. There's usually a component of a mental health component there. So depression, anxiety, maybe a little cognitive imbalance. Can you talk about the relationship between the concussion, the brain injury, and those kind of mental health issues that people are facing, kind of in the short and long term?
Yeah, I mean, when you take a look at those symptoms, they're going to be an outcome of a brain that has just been traumatized. So the analogy that I give patients is you getting a concussion is kind of like me pouring water on my laptop. I can't tell you what's going to happen after that. And I don't know which programs are going to work and which ones aren't going to work. Maybe my space bar still works, and that's a function of like neck pain, right? But maybe my return key doesn't work, and maybe that manifests as you getting a little bit more anxiety. I can't tell you what's going to happen or what isn't going to happen, but there are patterns that we do see with the brain when it's under stress or when it's going through these stressful kind of states. Different areas do shut down. And so if you take a look at the brain as a house, Kylie, the first thing we would do if we built a house is we build a really stable foundation, right? And in that foundation, we put a lot of things down there that we need, but we don't want to think about. In your house, that's like plumbing, heating, sewage, electricity, right? In the human brain, that's controlling things like gut function, blood pressure, digestion, really basic postural reflexes, right? Subtle things that you shouldn't put any bandwidth towards whatsoever. And then what happens is we start aging and getting older is we start stacking layers on top of that, right? So first, second, third, we all kind of metaphorically speaking live in this third story of the house, the VIP suite, which is the frontal lobe, right? That's the CEO executive part of the brain where, Erik and Kylie live to have critical thinking and memory, and we can kind of process information. But all of those lower areas of the house have to support us in order for us to live upstairs in our third story. Now, if you had a flood or a leak or like a fire in your basement at your house, you wouldn't just hang out upstairs, would you? No, You'd go put that fire out and take care of what's going on downstairs. And the brain does the same thing, metaphorically speaking. These lower areas of the brain now demand more bandwidth. And so you'll see blood flow changes on an MRI or a functional MRI, but you'll also see changes in functional activity of these neurological circuits in the brain. So people talk about specific areas like the dorsolateral prefrontal cortex, and we go after that with like depression and anxiety and things along those lines. The orbital frontal cortex heavily regulates like emotional centers. So we're getting to areas like the insula, the amygdala, and for those of you who are listening, you don't need to know those terms, just know that these are emotional centers. What happens is these feedback loops that control these deeper areas of the brain are no longer able to do their job. So now they manifest as symptoms, and it could be depression, it could be anxiety, it could be PTSD, it could just be like fear, right? Because now these areas of the brain that kind of respond to those centers are no longer getting the feedback to say, hey, everything's okay, everything's kind of calm. And so now you're dealing with lower areas of the brain that their job originally was to make sure that those responses are there. But as you build the brain on top of all that, those areas are now supposed to say, hey, everything's fine. I've got you, right? You're in a safe environment. When you don't have that response or that feedback loop continuously telling you that, now these symptoms come out. There's so much more complexity to that. Inflammation plays a role. Sometimes genetics play a role. Genetic predisposition can be a real thing for some conditions, not all. And even nutritional factors can play a role. But essentially what you're seeing is you're seeing a manifestation of that neurological activity where the feedback loops are now being disrupted and symptoms are now manifesting before where they weren't.
These manifestations of things like depression, anxiety and whatnot, not so much the chemical imbalance, but more the disruption of those microfiber kind of tracks in the brain itself that may bode well for healing future, and it won't necessarily stick around as long as concussion treatment is properly adhered to. Is that kind of a conclusion I might be able to draw?
I think the whole chemical imbalance conversation is very, I don't want to say outdated, but I think we know a lot more. So I'm going to put it this way, right? So most people who have depression or are dealing with anxiety, they'll be put on an SSRI, right? So a selective serotonin reuptake inhibitor, which means that you have access to more serotonin. Well, what we're finding is that it's not actually just the imbalance of serotonin, but what's going on is that these molecules and these medications actually have anti-inflammatory properties where they can actually calm down immune cells in the brain called microglia. Well, these microglia kind of get turned on. There's a great book called The Angel and the Assassin. These microglia are your friends until they're not. So when they get flipped into a different phase, what happens is these microglia essentially get turned on, and now they start promoting inflammation and taking out healthy neurons. The problem with that is they're promoting inflammation and taking out healthy neurons, right? And that's not a good thing in any capacity whatsoever. So you need to turn them off. SSRIs have a mechanism where they can actually calm down microglial cells, which calm down inflammation, which may be one of the most prominent mechanisms for them. But I'll tell it this way. If anxiety, depression, and PTSD were actually chemical imbalances, then there would be no way that transmagnetic stimulation would be able to take out those symptoms, because they're not giving you more serotonin or more chemicals. Mm-hmm. They're stimulating the brain neurologically via electrical circuits. And so what we're noticing now is that when you stimulate, and this is the same thing with glia, when you stimulate different circuits specifically, you have a rebalancing of these feedback loops. So it's all about neuroplasticity. Now, I'm not saying it's that easy of saying, oh, put your hat on, stimulate the left dorsolateral prefrontal cortex and excite it, or inhibit the right side, right? Because it's not that simple. But there's a lot more to the story. And so theoretically speaking, yes, you should be able to treat a lot of these mental health outcomes. But once again, if you were somebody who was really anxious before the injury, and now all of a sudden you have a pretty bad TBI via an auto accident, you might be more prone to anxiety afterwards. Maybe that means you are for a long duration of time. Maybe that means you might need medications, treatment, cognitive behavioral therapy, nutritional work. I mean, we just don't know. But what I'm going to tell you is that there's a lot of potential mechanisms there, which also means that there's a lot of potential opportunities for treatment. It's just not straightforward. So the mental health component is a really big factor. And for patients that come in with a lot of that, I won't hesitate to send them out for a neuropsych evaluation, because it at least documents it. It tries to quantify it, and it shows them, one, that they're not crazy for feeling the way that they feel, but it's a real thing for them, right? And as a doctor, I need to be aware of that, because those things can be limitations for us in the long term if they're not addressed properly.
Yeah, I'm so happy you mentioned the neuropsychiatry component. I mean, even in my really limited acute, focus in my own clinical practice back in the day, we would have neuropsychiatry come in, especially on those folks that were suffering from subarachnoid hemorrhages, and oftentimes you'd have these personality changes and these just wide emotional swings that just came along with the injury, and it often helped, like you said, just kind of put some dots together, ease some fears for family, for the patient. Help the doctor know, what's going on, what's not. So yeah, I love a good neuropsych consult. So thank you for that.
Of course.
Couple questions that I had to wrap us up. The one thing, just being the subject matter expert, what do you think are the most kind of critical gaps today in, let's say, public education about concussions or mild traumatic brain injury, and how can the medical community address those gaps?
I take this stance from what I've seen clinically, is that there are a lot of people out there who are struggling with outcomes from concussions and brain injuries, but nobody would be able to tell based off of talking with them or seeing them. If I came into your office and I was wearing a cast or I was in a wheelchair, you would inherently recognize that and treat me differently based off of that. You'd know that something happened in my past, or that I'm dealing with some sort of problem in my life. But with a concussion or a traumatic brain injury that has not manifested, where you've got posturing and changes in your balance and things like that, people get treated the same. So expectations are the same. Friends expect the same from you. Family members do as well, right? Opposing counsel will try and grill you and say, well, you look fine. Why aren't you fine, right? It's truly the silent epidemic. And that is a massive problem for so many people, is that they go through this horrific experience, and all of a sudden now they're like, listen, I feel so different, but people don't understand that they have to treat me differently now based off of that. So they feel limited, they feel like they've been excluded. And then more importantly too, unfortunately, there's people out there who are like, listen, I don't see anything wrong with you, so I don't think that there's anything wrong with you. So I think just recognizing, much like you can't see depression, you can't see anxiety, you can't see PTSD, I think a lot of people make assumptions based off of what they physically see, and that's not necessarily wrong, but if we know more and we understand more, then we can be more empathetic to these patients who are stuck between a rock and a hard place with their condition.
I'm such a proponent of that silent epidemic. I saw so much of that just working solely in a neuro ICU setting, having colleagues in the medical ICU or the cardiac ICU. I mean, there was somewhat of I was going to say unspoken. Sometimes it was said out loud that neurological ICU and neurosurgical ICU wasn't real critical care because oftentimes they may not be hooked up to, 8 different vasoactive drips and they're on ECMO or whatever, but they are just as critically ill as anybody in those other units. Just, you can't see it. I can't.
Exactly. I think that is a hard part for a lot of patients, is that they want to get back to living their life. They're limited based off of what has just happened, unfortunately. And that creates enough angst, but then let alone hearing it from family members, colleagues, friends who are like, what's wrong, right? And then they start questioning that. That's a really hard spot to be at. And so counseling that, preparing them for that, or at least saying, hey, listen, this is my line. I was like, listen, I know you didn't sign up for this. I know this wasn't on your bucket list. I know no one wrote you a book on how to handle this. So you're kind of in uncharted waters, but that doesn't mean you can't write the ending to your story in a way where you can actually have an opinion or at least go the direction. So there's much to be said about that. And if people had more empathy or they were more aware of that, they'd probably be able to support individuals who are in that state a little bit easier.
So good to have a champion like you who's kind of walked in those shoes and now is on the other side of that, again, championing that very cause. So that's pretty cool. One last thing I always like to ask, of course, if you, Dr. Erik Reis, had unlimited resources that you could research, a particular aspect of concussion or brain injury in whatever area you'd like, treatment or prevention, what would it be and why?
Here's where this gets really interesting, right? So we've talked a bit about like the medical literature and the data. As it stands today, the medical literature doubles every 73 days. That is how fast papers are being published, data is being produced, and information is being disseminated. There's no way that I will ever be able to keep up with all of that. So it is changing so quickly. One of the areas that I think is really interesting to me, that I've been hooked on for probably about 2 years now, is this whole area and focus of trying to upregulate vagal tone and vagal nerve function. So for those of you out there who don't know what I'm talking about, you can have a yin and a yang for your brain and body, and it's you. One is your stress response, your fight or flight, your sympathetic kind of response, right? So you need that in so many ways and so many factors. What happens is when you have a traumatic brain injury is you kind of default to staying in that state, okay? And that's unfortunate because now everything just seems like it's harder, more difficult, more inflammation, more pain, all the things think you don't want, right? The yang to that yin, the opposite of that, is this rest and digest, this parasympathetic state. So these collectively, two states together are called your autonomics. I tell patients these are kind of your automatics. These are things that happen in the background, but once again, you shouldn't have to think about. So if I shine a light in Kylie's eye, he's going to have a pupillary response. That's an automatic, autonomic response that he doesn't have to think about, okay? And that's great, because if you did, you'd drive yourself crazy. What they're finding, and what they've known for a while, is when you stimulate the vagus nerve, different things happen to the brain. Okay. The original research on vagal nerve stimulation occurred with individuals who were dealing with seizures and epilepsy. And it was essentially epilepsy that was not responding to traditional factors and traditional standards of care. What they were doing is they would massage like the carotid sinus over the left side of the neck. Well, what they found around your carotid artery is that there's a little nerve that wraps around the carotid artery. It's a branch of the vagus nerve. It's a great peripheral location to stimulate the vagus nerve to try and change the brain centrally, right? So you're using a peripheral modality to change the central integrated state of the brain. And so it got people thinking, well, like, why don't we create devices and tools and therapies for this? As much as we want to think those devices do what they're doing, you stimulate your vagus nerve every day. When you take a breath in, you take a breath out, you just stimulated your vagus nerve and you stimulated your sympathetic system as well. Anytime you're digesting food, you're humming, you're singing, you're chewing things, you're stimulating your vagus nerve because that's kind of the functionality of it. But these tools, these peripheral vagal nerve stimulators, are really cool. And they're already FDA cleared for cluster headaches and migraines. They're getting clearances for anxiety, depression, and PTSD. They're investigating this for concussions, TBIs, post-stroke. They're doing research on obesity with it. They're looking at it to treat things like rheumatoid arthritis, which completely flips the discussion on its head. But yes, you can stimulate the neurological system to create an anti-inflammatory response. There's 3 different mechanisms based off of that already. But there are special forces in the United States, armed forces, we'll say, that are using vagal nerve stimulators to learn multiple languages 25% faster than they were doing on their own. So it challenges the entire norm of what we thought we needed to do. And so when I take a look at it, I'm really bullish on vagal nerve stimulation. I think it's still quite early in the research and the data, but we're using this with every single patient that walks through the office. I'm using it on myself. Because what it's doing is it can balance out that teeter-totter, that yin and that yang, to give you an appropriate response so that when you need to be stressed, you go into stress state, but then you go right back to neutral. It can calm people down, hopefully help with their symptoms, improve blood flow, have an anti-inflammatory response, and just potentially make people feel better about themselves. So this whole vagal nerve stimulation state is interesting, and I would love to put a ton of money behind it.
I can admit that I know a lot about that blooming technology field, but you've definitely given me something to look at and read into now. That sounds fascinating. Just all the potential implications for technology like that. That's really cool.
I love what you guys are doing. I know you guys are helping people in so many ways, and I think it's just so important for us to have these discussions and conversations because you never know where they're going to go. You never know who you're going to impact, and even if somebody doesn't reach out, they just have a little bit more knowledge and education, then this was worth it, 100%.
Working well together like this, the medical side of things, the legal side of things, I mean, it takes a whole team to get our patients, our clients where they need to be, and finding, partners like you that can advance the cause, that can educate, and again, kind of champion these issues is really what we need. So thank you so much for sharing your knowledge and your expertise.
Yeah, thanks for having me. I thoroughly enjoy having these discussions, and once again, I just appreciate what you guys are doing for the community.
All right, friends, that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. Thanks again to Dr. Erik Reis for joining us today to discuss brain injury, concussion, and all things brain-related. We hope you enjoyed this conversation as much as I did. If you wouldn't mind hitting that like button and smashing that subscribe button as well, you can keep up on our latest and greatest content. And as always, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.